When we looked at the brainstem cross sections, we're going to look at them again today, but in a different way. I talked a little bit about this little dot that kind of hangs around with the STT tract. I don't know if anybody remembers that, but it's in all the cross sections. And it's something that I labeled as the sympathetic tract. And today we're going to talk about exactly what is the sympathetic tract. Hopefully now you've come to recognize my sagittal section. So here's my brain, thalamus, midbrain, pons, medulla, cerebellum, spinal cord. Okay, it's over on the left side. Over on the right side are representations of faces. Okay, we're going to draw what Horner syndrome looks like. The first one we're going to look at is the intact, and then I'll show you what somebody with Horner syndrome looks like. This is important stuff. This is a standard boards type question. Okay, so you really need to get a feel for what Horner syndrome is, how patients present with Horner syndrome. And I know that in differential diagnosis, Dr. Igler and Dr. Grandio will probably pull out a patient case with Horner syndrome. Okay, so this is something you need to know. Let's start with labeling some stuff. So hopefully everybody recognizes this as the thalamus. And the sympathetic tract actually starts in something underneath the thalamus as a structure. And I'm just going to represent it as a red dot here. Have you guys covered the hypothalamus yet in P3? Not yet?
We'll be doing more autonomic stuff next.
Gotcha. Okay. Well, this is the hypothalamus. This is my representation of the hypothalamus. Sits under the thalamus, right? So hypothalamus. Involved in a lot of endocrine regulations. Yes?
Is this different from the subthalamus? Or?
Yes, the subthalamic nucleus is different than the hypothalamus. The hypothalamus is the structure itself. It sits under the thalamus as well. Okay. The sympathetic tract, that little dot that we looked at through all the different cross sections, actually extends from the hypothalamus all the way down through T1 through T3 spinal cord levels, or something like this. So down here, I'm going to say this is T1, T2, and T3. Okay. Coming down in the lateral gray horn of T1 through T3, there exist neuronal cell bodies. They're going to be involved in this pathway. Okay, we haven't really talked about the lateral gray horn yet. Has anybody heard of the lateral gray horn? No, haven't covered it yet in P3 or anything? Okay, you will get there. But it's specific for the autonomic nervous system. It's in, so the lateral gray horn is going to be in your thoracic, spinal cord regions, and a few of the lumbar. Okay, so specifically T1 through T3 in this particular pathway. There's also going to be another player here that's going to be important. I'm going to represent it outside. This is something known as your superior cervical ganglion. Okay, your superior cervical ganglion. So the sympathetic tract starts in the hypothalamus. Neuronal cell bodies in the hypothalamus send out axons that travel through the midbrain, the pons, medulla, and all the way down through the spinal cord to synapse at the level of T1 through T3, the lateral gray horn. Those spinal cord levels. Okay, I'll label that. These are specifically neuronal cell bodies in the lateral gray horn. Okay, Okay, those neuronal cell bodies, let's see if I can get it to stay with the color, in turn send out axons that travel up and synapse with the superior cervical ganglion. Okay, and in the intact situation, superior cervical ganglion, neuronal cell bodies in the superior cervical ganglion sent out axons that synapse specifically with 3 different things. Okay, looking here in the intact face. Okay, the thing that's not going to change is it's a happy face. Okay, intact, you're going to have great big old open eyes, eyelids fully open, okay? And you're also going to have just a normal sized pupil. Everybody got it? Looking back here, the superior cervical ganglion, neuronal cell bodies are going to send out axons that synapse with 3 different things. The first thing is going to be a muscle that's involved in maintaining eyelid opening. Does anybody remember the name of the muscle innervated by cranial nerve number 3 that initiates eyelid opening? Levator palpebrae. Great. This muscle is going to be your, after levator palpebrae does its thing, opens the eyelid, you need another muscle to maintain that eyelid opening. Okay? This is going to be your superior tarsal muscle. Superior tarsal. And then, so I'm just going to say maintains eyelid opening. Okay. That's just a normal pupil size. The second thing that is involved in Horner syndrome is going to be maintaining, so here's axons from the superior cervical ganglion send out and synapse with the muscle that's responsible for pupillary dilation. Does anybody remember which muscle that is? We talked about it being under sympathetic control way back when. What is it? Dilator pupillae. Okay, I'll put that in here. So dilator pupillae. Okay, your dilator pupillae is going to be responsible for pupillary dilation. Okay, so 2 things so far. We have the superior tarsal muscle. The superior tarsal muscle is responsible for keeping your eyelid fully open after levator palpebrae initiates eyelid opening. The second is going to be the dilator pupillae. Okay, the dilator pupillae is that muscle that's responsible for dilating or keeping your eye dilated. And then there's going to be one more axon sent out by superior cervical ganglion, and that is going to provide innervation to facial sweat glands. So facial sweat glands. Okay, facial sweat glands are there to help with cooling of the face with exertion. Okay, so in the intact sympathetic tract pathway, you have axons being sent out by neuronal cell bodies in the hypothalamus. those axons travel down through the brainstem cross sections that we saw. We saw the sympathetic tract previously. They travel down to the level of T1, T2, and T3 to synapse with neuronal cell bodies in the lateral gray horn. Those neuronal cell bodies then send out axons to the superior cervical ganglion. And the superior cervical ganglion then sends out axons to synapse with three different things. Okay? Superior tarsal muscle, responsible for keeping that eyelid open. The dilator pupillae, responsible for pupillary dilation. Okay? And then facial sweat glands, okay, responsible for cooling of the face when there's overexertion. Questions about that? Does that make sense? So, oh, no, I thought I saw a hand go up. It didn't. Okay, this is intact. This is the intact sympathetic pathway. Now let's look at somebody who has Horner syndrome. Horner syndrome is a disruption anywhere in these three regions. Okay, you can have a disruption here due to a spinal cord injury. You could have a brainstem stroke. Anything that disrupts this sympathetic tract pathway right here is going to cause Horner syndrome or symptoms of Horner syndrome. You could also have a disruption here with these T1, T3 neuronal cell bodies, the axons that are sent out, any disruption in this region. Or you could have another disruption here between the superior cervical ganglion and innervation of those three specific muscles. Anything's possible. Okay, but you know when you see Horner syndrome that it's a disruption to the sympathetic tract pathway somewhere. Okay, so this is let's go ahead and make this a right side. The right side is over here. That's right, yeah. And then the left side's over here. Okay, Horner syndrome is going to present ipsilaterally. Okay, so let's say that this is a problem with the right sympathetic tract. Okay, problem with the right sympathetic tract here. That means everything we're going to see is going to be on this person's right side. So the smile is not affected. They're still smiling. Okay, and the left side's not affected because it is a disruption of the right sympathetic tract. So the first part of Horner syndrome, or the Horner syndrome presentation, is called ptosis. Okay, I'll represent that here. This is P-T-O-S-I-S. And ptosis is just a fancy word for drooping eyelid. Okay, so that person's not able to maintain their eyelid fully open because innervation to the superior tarsal muscle has been damaged. Okay, so ptosis, nothing more than a drooping eyelid. Okay, second part, Horner syndrome. That person is going to be presenting with a constricted pupil. The name for a constricted pupil is here. It's called miosis, M-I-O-S-I-S, and that's pupillary constriction. And that is all the time, not just in response to bright light. Okay? The reason why the pupil appears constricted all the time is because the dilator pupillae is not innervated, because there's disruption somewhere along here in the sympathetic tract. And then there's going to be one more thing that we need to worry about, and that is going to be a red and dry face, half of a face. Okay, so this is due to the lack of innervation to the facial sweat glands, and this is known as anhidrosis. So anhidrosis is going to be your face gets hot and red, and there's no sweat to cool you down. So the anhidrosis is due to lack of facial sweat. Three different things you need to remember. Meiosis, ptosis, and anhidrosis. Meiosis, ptosis, anhidrosis. Those are the three things that are involved in Horner syndrome. Okay? Lots of different ways it can present, but it is something that is outside of our scope of practice and needs to be referred. Okay? Questions about Horner syndrome? Yes? Harlequin syndrome, and maybe, I don't know, what is Harlequin syndrome? I'm not sure. Dr. Brett would be the, do you know Dr. Blair? I've never heard of Harlequin before, so Dr. Brent would be the person to ask, the local person. But yeah, so somebody goes to the gym and works out, and one half of their face is normal looking and sweaty, and the other half gets bright red and is dry. That's anhidrosis. Okay? And that constricted pupil all the time, right? Meiosis. That eyelid drooping, ptosis. All right, three different things. Now, let's move on to cranial nerves and blood supply. We're going to put it all together. This is where the first half of the course meets the second half of the course. All we're going to do is draw in the cranial nerves that we covered way back when. And the first cranial nerve is going to be up here in the midbrain at the level of the superior colliculus. You remember that one? That's going to be your third cranial nerve number 3. That's going to be oculomotor. And just to make this easy to see everything, I'm just going to draw everything on one side. And to make it clear, I'm just going to draw my midline here so you can see that. Okay. Now, next cranial nerve, going down in order, you have 3. Cranial nerve number 4. Cranial nerve number 4, like I said, is the only cranial nerve to exit to decusate. Okay. It's the only cranial nerve to exit dorsally. All the others exit ventrally. In addition, and it exits dorsally and then comes around the front to appear ventrally. It is also the only cranial nerve that decussates. Okay. Going down 3, 4. Here's cranial nerve number 4, and that's going to be your trochlear. Okay, next cranial nerve in line is cranial nerve number 5. Comes out here in the lateral pons. Cranial nerve 5, remember that big one that's involved in a lot of the sensory information processing, and this is going to be your trigeminal. Okay. First one to come out of the pons. Okay, so 3, 4, 5. 5, the next cranial nerve number 6, comes out more medial. It's medial pons here, and that's cranial nerve number 6, and that's going to be your abducens. Okay, just lateral to cranial nerve number 6 is going to be cranial nerve number 7. It's going to be your facial. And just lateral to cranial nerve number 7 is going to be cranial nerve number 8. That's your vestibulocochlear. Okay, 5, 6, 7, 8, 4 that come out of the pons. Moving on down to the medulla. We have 2 cranial nerves up front. There's going to be one here, cranial nerve number 9, glossopharyngeal. Under cranial nerve number 9, in order, is going to be cranial nerve number 10. That's vagus, the wanderer. Okay. So just a quick review, and then one more that we talked about coming out of the preolivary sulcus. So here is my preolivary sulcus bilaterally. I'll put it on this side. This is going to be cranial nerve number 12, hypoglossal. Review of the cranial nerves that actually arise out of the brainstem proper. Ones that we're going to talk about. 4 above the pons. Really, there are just 2 here in the midbrain. 4 in the pons, and then 4 below the pons. The last one comes down from C1 through C5, but we're not going to worry about that one. Okay, these are all the cranial nerves that are going to be involved in what are known as brainstem vascular syndromes. Okay, these are always can be challenging to remember, and I like to do it this way because if you know where your cranial nerves are located and you can identify a function of a cranial nerve in one of the brainstem vascular syndromes, you automatically know it's either in the medulla, the pons, or the midbrain. Okay, and then we're just going to add a few other things to it, but it's just that simple. When it comes down to the blood supply, hopefully everybody remembers the blood supply to the brain, right? This is going to be the vertebro-basilar system. So I have 2 cranial nerves that are 2 arteries that are coming up here, arising from the right and left sides. Okay, and they're going to come together and meet at about the level of the pontomedullary junction. Which arteries are they? Vertebral, great. Okay, so these are your vertebral arteries. if you had to take a guess, which artery do you think supplies the area around cranial nerve number 12? Vertebral. Yep. So looking at the territory for the vertebral artery as far as this is concerned, this is looking at it from the outside, and you can clearly see that if a person's presenting with a problem that involves tongue musculature, you know you're in the medulla, right? So that's where the problem is. Okay, so it's going to be medial medulla. Okay. Two vertebral arteries, left and right, coming up, meet at about the level of the pontomedullary junction to form one main artery that proceeds all the way up to just above the level of the third cranial nerve. And that artery is basilar. Okay, so there's the basilar artery, and there's also these little branches coming off that are your pontine arteries, right? So they just supply the pons in the middle. So you can say basilar or pontine. So just pontine arteries are just little branches coming off the basilar that help supply the medial pons with blood. Okay. Moving forward, there is an artery here. Which one do I want to do? Let's do this green. There's an artery that comes off the vertebral arteries, left and right, to supply the posterior inferior surface of the cerebellum with blood. Does anybody remember the name of that one? That's pica. P-I-C-A, posterior inferior cerebellar artery. Okay, pica. And pica is going to be responsible for supplying the lateral medulla with blood. And you can see that here. And typically when pica is affected, the person is going to present with signs and symptoms of cranial nerve 9 and 10 problems. Okay, so swallowing difficulties, maybe a hoarse voice. Okay, so we have vertebral arteries, medial medulla, pica, lateral medulla. Moving up, let's look at medial pons. The basilar and or pontine arteries supply the medial pons with blood, and that's going to be in this area right here. Okay, and if that area specifically is affected, you're going to see signs and symptoms of cranial nerve number 6, abducens dysfunction. Okay, just based on where that basilar pontine system is, it's going to be medial pons.
That's what the basilar and pontine arteries?
Sorry? Yeah, basilar and pontine. Yeah, basilar artery, a disruption of the basilar artery is going to cause a much bigger problem called locked-in syndrome that you'll learn more about next year in neurorehab. Okay, so right now, you should know that both basilar and pontine arteries are responsible for supplying that medial pons. Okay, we also have coming off the basilar artery here, you have a pair of arteries that go both left and right and supply the superior inferior surface of the cerebellum, or anterior inferior surface of the cerebellum with blood. Okay, and that's going to be pica's sister Ica. That's going to be the anterior inferior cerebellar artery. Okay. And then you can see that the territory for Ica is going to be here. It's going to be your lateral caudal pons. Okay, so somebody with a problem with pica are going to have some facial droop, and they're going to have vestibular problems as well. Balance, dizziness, that sort of stuff. Okay, that's with Ica. And then, so we have lateral medulla is vertebral artery, medial medulla, vertebral artery, lateral medulla is pica. Medial pons is going to be basilar pontine artery, lateral pons is going to be Ica. Moving on up, there's going to be one more, and we're going to look at medial midbrain syndrome. Coming off the basilar artery, two different chutes that are going to appear just above the level of the third cranial nerve, going left and right. These are going to be branches of your PCA, or your posterior cerebral artery. Okay, left and right. That's going to be posterior cerebral artery. Okay. And the medial midbrain syndrome that we're going to look at is going to be due to a disruption in either the basilar or the PCA. Okay, so that's going to be the territory right there, but that's going to be medial midbrain syndrome. And that person may present or will present with signs and symptoms of cranial nerve 3 dysfunction. Just putting it all together. Blood supply from way back when, just nothing more than overlaying it right where your cranial nerves would be. So if you could draw your blood supply and you can put the cranial nerves in the right spaces, identify medial versus lateral, you can figure out what artery is going to be involved. And can also figure out patient presentation based on the cross sections we're going to look at here in a minute. Questions about that? Hopefully it's pretty obvious, but I think it is. But this is always a challenge for people to remember what these things are. Okay, cranial nerves and blood supply, overlaying. Now all we're going to do is we're going to look at the cross sections that we looked at when we looked at the brainstem a couple weeks ago. Okay, specifically we're going to be looking here, we're going to be looking here, and we're going to be looking up here. Okay, 3 different cross sections, same as we've seen before. We're going to go through and just start labeling stuff. Here. Let's start with, actually, the name of this brainstem problem is going to be a medial medullary syndrome. So it's going to be affecting the medial portion of the medulla. Yes, Julia? The trochlear won't have a patient presentation. Okay, so that there are specific syndromes that you need to know about, and these are those. There's no patient presentation syndrome that you need to know that involves the trochlear. Okay, good question. Same with trigeminal. Trigeminal, yeah. Okay, so remember, let's look at that picture real quick. Okay, good question. So remember, the trigeminal nerve is going to exit lateral pons right here, but remember that main sensory artery, main sensory nucleus. So you're going to have the motor the spinal nucleus of trigeminal. Remember that big old nucleus is going to be here, so it actually comes all the way down. So you're going to see it in all these cross sections. You won't see the main the spinal nucleus of trigeminal and the midbrain, but you're going to see it all throughout here, the pons and the medulla. Remember that big sensory nucleus? Okay, the spinal nucleus of trigeminal, we're going to see that coming through. Okay? But we're not going to see any motor functions for trigeminal. Any other questions? Hopefully you can see where I'm going with this. Yes? Question? Let's look. Let's look. I need you to see it. Yeah, let's look to see where it comes from. So good question. You guys are on the right track. You're thinking in the right direction. And we're going to start here with the medial medullary syndrome. This is something you've seen before. And this is what the brainstem cross-section that we saw previously. And let's go ahead and label this as left versus right. So remember, this is going to be most ventral up here. Oh, let me put that in there. So this is dorsal. And then this is ventral. Okay, so in other words, it's facing like this. So this side's going to be the right side, and this side's going to be the left side of this particular cross section. Okay, so this is the right side, and then this is going to be the left side. Does this look vaguely familiar? We saw it a couple weeks ago, the cross section through the brainstem. This is coming back for you. Okay, thinking about the medulla, let's start out with the cranial nerve. There's a cranial nerve that exits here in the pre-olivary sulcus. So, anybody remember what cranial nerve that is? 12. That's cranial nerve number 12. This is the hypoglossal. So, this is going to be the hypoglossal nucleus. Right? And then this is cranial nerve 12 as it exits that pre-olivary sulcus. Right, see where we are? This is just a flat-out cross-section, transverse section right through the medulla. Okay, so since this is the pre-olivary sulcus, that makes this thing here inferior olivary nucleus. Okay, remember, inferior olivary nucleus is going to be associated with cerebellar function, motor learning. Thinking about what's going to be most ventral, all these things down here. You know, question? No? Sort of. No? Okay. These are most ventral structures. Does anybody remember what this is that's most ventral in the medulla? Hasn't crossed over yet, by the way. We're still well above the crossover point. It's going to be more rostral medulla. But this is going to be your corticospinal tract, your CST. Think about other things that we've talked about. We just talked a little bit about the main sensory and spinal nucleus of trigeminal, and that's always going to be this kidney bean shaped thing. That's going to be your spinal nucleus of trigeminal here, and that's where that big old nucleus is coming down and projecting into the medulla. Responsible for receiving sensory information coming from the face, head and face.
Of trigeminal?
Of trigeminal. Mm-hmm. Spinal nucleus of trigeminal. Yeah, so there's that main sensory and spinal nucleus of trigeminal, which they function together as the same thing. They receive all that sensory information coming from all those cranial nerves that receive sensory information from the face and the head. Okay, moving on. There's also this other tract that I know you guys know very well. This little circle right here is going to be your spinothalamic tract. So that's your STT. Okay. And the one that we covered today usually hangs out with the STT. There's this little tract here. Bless you. That's going to be your sympathetic tract. That's the one, if you disrupt this tract, you get Horner syndrome. Meiosis, ptosis, and anhidrosis. Okay, now moving very medial, we have, I talked about this being an elongated shape previously when I talked about brainstem cross sections. And it's medial, so this is going to be your medial lemniscus. Okay, medial lemniscus is carrying information from ECML. Okay. Vibration, proprioception, fine touch. On the top or dorsal to the medial lemniscus, it's going to be this tract that we've talked about that's involved in coordination of eye movements or conjugate eye movements. So it's responsible for connecting that vestibular nucleus with the nuclei of cranial nerves 3, 4, and 6 bilaterally. Does anybody remember the name of that? It's an MLF. It's your medial, because it's medial, longitudinal fasciculus. So your MLF, medial longitudinal fasciculus. Okay, and one thing we hadn't talked about. So with medial longitudinal fasciculus, it's involved in keeping those eye movements smooth and conjugate, or if you're looking to the left, both eyes are looking to the left. If you're looking to the right, both eyes are looking to the right. You're not having eyes going in different directions. If there's a disruption to the medial longitudinal fasciculus, that results in something called a disconjugate gaze. So that means eyes aren't going to the same side at the same time. Okay, a conjugate gaze or having conjugate vision means both eyes are looking either right or left. What happens is if you have a disconjugate gaze, that means my right eye might be looking to the right, but my left eye might be looking to the left or straight ahead. They're not both looking in the same direction.
Is that what we refer to as lazy eye?
Oh, no, that lazy eye is a little bit different. A disconjugate gaze is can be either eye. It's, yeah, a little bit different. Okay, moving on to the next one we have, let's make it bright orange. This is going to be that nucleus that doesn't know who it belongs to. It's motor nucleus for both cranial nerves 9 and 10. Does anybody remember the name of that nucleus? Yep, that's your nucleus ambiguus. Do you have a question?
Oh, no.
No? Okay. Okay, nucleus ambiguus. That's going to be the motor nucleus for cranial nerves 9 and 10. Works for both of them. And then there's one more area back here that we labeled previously. We'll label this again. This is going to be a protrusion a little bit of your inferior cerebellar peduncle. Remember, your inferior cerebellar peduncle is the main peduncle where all that afferent information coming into the cerebellum comes in. So this is going to be your inferior cerebellar peduncle. Oops. Okay. We talked a little bit about the artery that supplies the medial medulla with blood. Does anybody remember what artery supplies the medial medulla with blood? Just talked about it a little bit. It's going to live right here, right where that cranial nerve 12 exits. Okay, that's your, yeah. It's going to be your vertebral artery. So left medial medullary syndrome is going to be a problem with vertebral artery. And we're going going to say it's the left vertebral artery that specifically has a problem here. So on the left side here, here's my midline. The vertebral artery is responsible for supplying everything in the medial portion of the medulla with blood. Specifically, it's going to be in between these dots. Okay, so that whole area that's affected, let's keep it the same color. The area that's going to be affected in medial medullary syndrome is here, because this is all the area that is supplied with blood by the vertebral artery. Specifically, you're looking at the left vertebral artery here. So all I've done is draw the structures in that medulla cross-section that you couldn't see from the outside. We already saw that cranial nerve 12 was going to be involved with medial medullary syndrome. Okay. Now, in addition to cranial nerve 12, what kind of patient presentation would you expect if the corticospinal tract wasn't working here? I hope somebody said motor. Motor what? Motor problems, right? They're gonna weakness, right? They're gonna have weakness because corticospinal tract has been wiped out. Now, if the medial lemniscus is wiped out, how's the patient going to present? Yep, lack of proprioception, vibration, and fine touch. Medial longitudinal fasciculus, they're going to present with a disconjugate gaze. Okay, if the hypoglossal nucleus is affected, which way is the tongue going to point? Toward or away from the lesion? Towards the tongue. You're going to ask that person to stick their tongue out, and it's going to deviate to the left side. So tongue deviates toward the side. And at the end of today's drawings, I have the slides set up, and I've left out ipsilateral versus contralateral, and that's going to be the group activity for today. You guys have to figure out whether it's going to present ipsilaterally or contralaterally. You're welcome. I know, it's great. Jonathan? Johnny?
Can you repeat all of those symptoms again?
Absolutely. Sure thing. So, if a person has a disruption to their corticospinal tract, that patient's going to present with weakness. Only on one side. You're going to figure out what side that is today. Okay? If the person has a disruption to their medial lemniscus, we've seen this before, they're going to present with loss of vibration, proprioception, and fine touch. Okay? If they have a problem with their medial longitudinal fasciculus, they will present with a disconjugate gaze. And then if the hypoglossal nucleus is affected, they're going to present with a tongue deviation. The tongue's going to deviate toward the affected side. So the tongue will point to the side of the lesion. Any other questions? And all these deficits, all these patient presentation findings are going to be listed on the slides for you as well that you're going to fill out today. Okay, but I'm happy to go through it and make sure. Did you have a question? No, just thumbs up. Okay, any questions? Okay, let's take a 10-minute break.